Thank you very much, dear Professor Mahdi, Professor Gafar, Professor Mu'min, all my friends. It's very hard to come after two excellent presentations and three wonderful discussions, actually, from Professor Mahdi, Professor Mu'min, Professor Budewi, and Professor Gafar. So the title is Unexplained Infertility.
دكتور ممكن نعمل سلايد شو؟
Yeah. Okay.
Thank you.
So the title is Unexplained Infertility. And by definition, the incidence of unexplained infertility is about 30% of infertile couples. It varies, of course, with age and with the location. And it is defined as the lack of an obvious cause for infertility for 12 months if the female is less than 35 years, and for 6 months if she is more than 35 years. How to reach a diagnosis of unexplained infertility according to EFRE? Only doing 3 tests: semen analysis, assessment of ovulation, and assessment of tubal patency. If the 3 are normal, then the diagnosis is unexplained infertility. And I think concerning this, ultrasound also is important. So ultrasound should be added as a 4th test to diagnose unexplained infertility. Other tests like ovarian reserve tests should not be performed routinely. Postcoital test does not have a meaning, and endometrial biopsy should not be performed as a part of routine investigations of infertile couples. And then the very controversial point, which is laparoscopy. And the committee opinion of fertility and sterility indicated that laparoscopy should not be performed in the evaluation of infertile female, but may be warranted only if you have high index of suspicion that something is wrong in the pelvis. To this end, despite this, if you take couples with unexplained infertility and you do laparoscopies, you can have abnormal findings in about 83% of patients. 70% will be endometriosis, 50% will be adhesions, and 20% will be a tubal factor. And also there are studies indicating that after laparoscopy for adhesions or endometriosis or tubal factor, the pregnancy rate will increase during the first 16 months after laparoscopy. So these are controversial data. Semen is okay, hysterosalpingography or saline infusion is okay, progesterone is okay, but laparoscopy is very controversial. And although there are no guidelines to indicate that laparoscopy should be done for cases with unexplained infertility, there are intervention data that would say that laparoscopy could increase the pregnancy rate in women with unexplained infertility past 3 years after the laparoscopy. As we've stated that the indication for diagnosing a couple with unexplained infertility is 1 year of marriage, the question comes, is 1 year a solid cutoff? So in fact, if you take couples with unexplained infertility, you will find that after 12 months of unsuccessful attempts, 50% will conceive in the following year, and another 12% in the second year. So 1 year is not a magic word, because if those couples stay for 2 years, the 50% will get spontaneous pregnancy, and if for 3 years, the data will indicate that from 60 to 80% will get pregnancy doing nothing, and this is very important. Then the third important question, is it truly unexplained? Is this truly unexplained infertility? And the answer, of course, is no, because there are some patients with genetic factors, some patients with ovarian or testicular dysfunctions, some patients, as you've indicated in previous presentation, with the sperm and oocyte problems, some patients with fallopian tube problems, some patients, as Professor Mu'min indicated or Professor Badawi indicated, with endometrial problems, either from organic lesions like fibroid or from dysfunction of the endometrium, as Professor Mu'min indicated, and implantation failure also, endometriosis, and the big issue is the immunology. So immunology constitutes the dark room, the area that is not exactly known in unexplained infertility. You may have autoimmune thyroiditis, antiphospholipid syndrome, systemic lupus, vasculitis secondary to diabetes, anti-nuclear antibodies. All these are factors that could be present and related to infertility, but they are not essential requirements for diagnosis of unexplained infertility. Unexplained infertility is diagnosed by semen analysis, hysterosalpingography or saline infusion, serum progesterone, and ultrasound. You don't need these tests to diagnose unexplained infertility, but they are, of course, definitely causes for unexplained infertility in different populations. So I have this first case. She's 31 years. She's married since 2.4 years. Her BMI is 25. She has regular cycles, mid-luteal progesterone 8 nanogram per ml. She did saline infusion sonography, which showed that at least one tube was patent, and uterine cavity is sonographically normal. The antral follicle count was 15. Sperm count is normal, and past history of 4 chromatin citrate cycles and 2 IOI cycles in one clinic. She was counseled about her chances of spontaneous pregnancy despite having 2.5 years of infertility, and she took non-specific treatment just for reassurance, and she had spontaneous pregnancy after 6 weeks. So even after 2.5 years of infertility and failure of clomiphene citrate and IOI cycles, spontaneous pregnancy can still occur in patients with unexplained infertility. And this rate of spontaneous pregnancy is 13 to 15% during the first year of attempt, which increases to 35% during the next 2 years of attempt. And moreover, the rate could reach, in some women who are young and having a good fertility profile, the spontaneous pregnancy rate can reach 80% following 3 years of unprotected intercourse. So even on the 3rd year in young couples, there is a high chance that pregnancy can still occur spontaneously. And the rate of spontaneous pregnancy, of course, will drastically decline after the 3rd year. So after 3 years of unexplained infertility, the rate of spontaneous pregnancy will definitely decrease even in women younger than 30 years. So the management of infertile couples with idiopathic subfertility needs individualized treatment. And this individualized treatment has several keys or several variables. For example, age. In older age, you will go on the fast track. You don't do a lot of trials before doing ICSI. You go for ICSI if there is a chance for good success in ICSI. The infertility history. The infertility history, if she's second in infertility, she has better chances than primary infertility. If she has 2 cycles or 3 cycles of IUI, you should not repeat this again. the treatment history, if she has been treated with clomiphene citrate or with letrozole or with gonadotropins, the cost of the treatment, an expensive treatment that has a lot of number to treat before you have a pregnancy is not a good treatment, even if it is evidence-based treatment. And the risks of that treatment, because, for example, you will see that NICE guidelines removed totally IOI because of the risk of multiple pregnancy with IOI. So this patient is 28 years. She's married for 3 years. Her BMI is 26. She's ovulatory with patent tubes, this time with hysterosalpingography. Sperm count is normal, and the motility is normal, and the morphology is normal. She visited 5 clinics last 11 months. She's tense, she's worried. Clinic 1, she did 4 cycles of clomiphene citrate and HMG. Clinic 2, she did PRP in 2 cycles for thin endometrium with clomiphene citrate. And in clinic 3 and 4, they offered her laparoscopy and hysteroscopy, but the patient refused. And clinic 5 offered ICSI, which she refused for economic reasons. She got pregnant on letrozole plus FSH. So despite the passage of 3 years, and despite the several treatment history that she had, still she can get pregnant with a simple treatment like letrozole and FSH. Another patient, 28 years, married for 3 years, BMI 26, ovulatory with patent tube by hysterosalpingography. She was given, despite the passage of 3 years, letrozole, 1 tablet per day from day 3 to 7, and FSH from day 5 onwards. And on day 9, right follicle 17, endometrium is 5, triple but 5. On day 11, right follicle is 20, endometrium still thin but triple. So despite the fact that the follicle was 20, we waited till the follicle became 25 and endometrium became triple and 9. HCG was given and she got pregnant. The message is that despite the passage of 3 years and several treatments, still you can use simple procedures. And the second message is that each protocol has a specific management. Each protocol has a specific management. So overtreatment in most cases is mainly related to misdiagnosis and undiagnosis of eligible cases for expected management. You do an overtreatment, expensive treatment, because we misdiagnosed who are the patients who are favorable for expectant management. So who are they? So the patients who are eligible for expectant management are women under 30 years, women with short infertility duration, women with simple past history of infertility treatment without aggressive measures, and women who do not have a history suggestive of other causes of infertility, like a lot of infection or previous pelvic surgery, etc. So the NICE guidelines in 2004 it stated that expected management for 2 years is the best choice when the age is less than 30. So this is the first guideline according to NICE 2004. And what we mean by expected management, this means active medical intervention, which requires that she will be aware of her ovulation time and the best period of unprotected intercourse. So she has to learn something about her physiology. And the main advantage in those who put the guideline is that expected management is associated with little incidence of multiple gestations with its known complications. So this is the first guideline in NICE guidelines 2004. If the long period of expected management cannot lead to pregnancy, ovulation induction by clomiphene citrate and letrozole is not effective for those couples. So according to NICE guidelines 2004, if expectant management did not lead to pregnancy, ovulation induction by clonfencitrate and letrozole alone are not a good idea according to guidelines. And as you've seen from our case presentations, they were used either with clonfencitrate with HMG or letrozole with HMG in patients who got pregnant after 3 years of expectant management. According also to NICE guidelines 2004, insemination cycle without ovarian stimulations will have little benefit. And this is a major difference between NICE guideline 2004 and NICE guideline 2013. So in NICE guidelines 2004, they still chose insemination as a treatment of unexplained infertility, but they suggested that insemination should be coupled to stimulation. Stimulation cycles in IUI, 3 to 4 cycles, are effective in women under the age 35. This is NICE 2004. But they indicated that COH IUI increases the risk of multiple pregnancy and that it is not effective in couples with long duration of infertility. The major shift in the guidelines was in the NICE guidelines 2013, where they recommended expectant treatment for up to 2 years, and then, if unsuccessful, just go to IVF directly. They ruled out the possibility of using intrauterine insemination as a possible intermediate treatment for couples with unexplained infertility. So this is the major difference between NICE 2013 and NICE 2004, that they eliminated IUI from the pathway of treating unexplained infertility. And this created a huge battle between specialists, and then came also this systematic review and meta-analysis that indicated that there is no difference actually between IUI and timed intercourse in patients with unexplained infertility, whether you're using COH or not using COH. And also the experience of a lot of us in this session. There are indications that IUI is not better than timed intercourse, and there are some respectable bodies that establish guidelines that do not confirm that IUI should be a treatment option in the pathway of unexplained infertility. And if you come to the question of whether to use clonfencitrate or letrozole with HMG in the treatment of unexplained infertility, meta-analyses showed that they are the same, whether you use clonfencitrate or letrozole with HMG, but not alone, because we indicated before that alone they are not a good option for unexplained infertility. So couples over 35 and couples with long duration of fertility are suitable candidates for IVF. And because of the risk of fertilization failure of IVF, then you should split in patients with unexplained infertility the oocytes between IVF and ICSI, which is a good idea, rather than using IVF alone, which could lead to fertilization failure, because in unexplained infertility, we don't know exactly what is the cause of the infertility. This story extends more in women with old age. In women with old age, IVF seems better option than IUI, as it is clear in the 4T trial, which was published in 2014, to compare treatment initiated after 2 cycles of IUI, to IVF in older women with unexplained infertility. And this 4T trial demonstrated that the pregnancy rate with IVF is better than the pregnancy rate and quicker than the pregnancy rate with IUI in older women. But we have to remember that in older women, there are a group that will not respond properly to ICSI, and they are not good candidate for ICSI. So we have to be careful in this group, like for example, Poseidon 4. So if you think that this group is a poor candidate of ICSI, you should not run always to ICSI, because cost-benefit analysis is important, and it is questionable that IVF in poor responders, according to Bologna criteria, is an effective treatment or not. So this patient is 38 years with unexplained infertility, 1 year. She had 2 cycles of IUI and HMG. In the second cycle, she got pregnant with 3 sacs with cardiac tube pulsation. She was reduced to an ongoing pregnancy to 24 weeks. So despite the fact that she's 38, she didn't do IVF, and she managed to get pregnant also. This algorithm or pathway for unexplained fertility is one of the excellent algorithms which shows that in women with over 39 years, irrespective of the duration of infertility, you can offer the patient 2 cycles of treatment with IUI, with FSH, or FSH alone. And if this was not successful, was not successful, you can go to IVF directly. If she is 35 years to 39 years, you should wait for 1 year before offering this pathway. And if she's not pregnant within 3 cycles of stimulation, you go to IVF. So the difference between 35 to 39 to more than 39 is that you don't give a lot of time here or a lot of treatment, you just go directly to IVF, whereas here you can offer 1 year. If the patient is less than 35 years, she should fulfill the criteria of 2 years. So if she is less than 2 years, you should complete expectant management up to 2 years. Then you can offer stimulations or IUI, and if they fail within 3 to 6 cycles, you can go to IVF. If the patient is more than 2 years duration, you go directly to stimulation, and if unsuccessful, you don't have expectant management here, of course, and you go directly to IVF, to stimulation, and if not successful, to IVF. So age is important in choosing the pathway for management of unexplained infertility. If it is less than 35, it is 35 to 39 or more than 39, keeping in mind to choose properly for expectant management. So diagnostic evaluation for infertility should include a comprehensive history and physical examination. Diagnostic evaluation of infertile females should be accompanied by evaluation, of course, of male partner. And women under the age of 35 should seek infertility evaluation if they have not conceived after 1 year of unprotected intercourse. And women over the age of 35 should seek infertility evaluation if they have not conceived after 6 months of unprotected intercourse. And a woman should seek diagnostic evaluation of infertility immediately if she has a medical history significant for oligomenorrhea, amenorrhea, advanced stage endometriosis, or any other condition. And diagnostic evaluation for infertility should include assessment of ovulatory function, structure, and patency of the reproductive tract, and semen analysis to diagnose unexplained infertility. Ovarian reserve testing should not be performed routinely, and routine laparoscopy should not be performed in women with unexplained infertility, and postcoital test and endometrial biopsy should not be performed as part of the routine evaluation of these patients. And thank you very much for accommodating me, and thank you, Professor Mahdi and Sharif and Professor Mo'min, for your invitation.
Thanks, dear Professor Dr. Hassan Ali, for nice presentation, as usual, elegant and very practical. Every time you present, you give us new lessons in the topic you present.
Thank you
I
very
want to
much.
ask a single question. In case of unexplained infertility, scheduled for IVF or ICSI, we may face recurrent fertilization failure or abnormal oocytes in high percentage of unexplained infertility. So, in your practice, do you prefer to give adjuvant therapy before starting IVF for unexplained infertility, or add investigations specific before starting IVF in order to avoid any poor IVF outcome?
Thank you very much for a good, very good question. So the question is that, are there adds-on that should be given for patients with unexplained infertility before ICSI? And you know, Muhammad, the problem is that there is no good evidence for a lot of these adds-on. And the incidence of fertilization failure with ICSI, not IVF, with ICSI, in couples with unexplained infertility, in our hand, it is less than 5%. It happens, but less than 5%. And when it happens, we try oocyte activation. I'm not sure that there is in the literature or in our experience treatments that could correct this situation.
So, evidence, there is a low evidence for a laparoscopy in unexplained infertility. But in your practice, what is the role of laparoscopy in unexplained infertility? It's a practical point, not evidence-based medicine.
It is very confusing. It is very confusing. Because data on laparoscopy show that if you do laparoscopy for women with unexplained infertility, you will have pathologies in a decent proportion of these women. But if you talk about pathway, this is the issue. If you talk about a pathway that consists of expectant management, stimulation, IUI, and ICSI, then you will see that the role of laparoscopy is not a major role. But there are patients, in your experience and Sharif's experience and Momin's experience and my experience, that you think that they really have a problem that needs to be tackled with laparoscopy. They did appendectomy, they did ovarian cyst before, they did something in the pelvis, they had repeated infection. So possibly you can do laparoscopy for those patients. I cannot blame someone who does a laparoscopy after 3 years of unexplained. But if we stick to the pathway, the issue is the pathway. So if we agree that the pathway is expectant management, stimulation, IUI, if we agree or don't agree about IUI and IVF, then this will limit the sidetracks. Did I answer the question?
Yeah. Clear. Last question. In the fourth case, you present, you wait for the follicle till it reaches 25 millimeters.
25 millimeters, yes.
So what is the criteria for triggering, in your experience, in soft stimulation and long agonist protocol and antagonist protocol?
This is an excellent presentation. I am from a generation who learned that biological response is important. And this was the literature of 1988, 89. When they do stimulation, they look at the cervical mucus, they look at the endometrium. So if you take 10 patients that are taking letrozole, some of them will have their best time at a size of 20. Letrozole. Some of them will have their best time at the size of 22. And some of them have their best time at 25. My advice would be at least 4 days after the last letrozole tablet, at least 4 days after the letrozole tablet, whether you're giving HMG or not giving HMG with the letrozole. And then if you wait enough for the endometrium, it will pass 9 millimeter definitely in letrozole. So this is a good sign. You wait for the endometrium also, not only for the size of the follicle.
So not follicle only, follicle
and days from the last tablet.
4 days.
Yeah, at least.
Yeah. Long agonist and antagonist. Does it differ or not?
Yes, it does. In long agonist, when most of the follicles exceed 20, not 3 or 4 or 5. When most of the follicles exceed 20, and when the days exceed 10, and when the days exceed 10.
Then
So this is important.
yeah.
With antagonist, it is confusing for me, but from my experience and from my friends' experience and from the literature experience, in the antagonist, if you have 5 or 6 follicles exceeding 18, you can trigger. And in the antagonist, you get what you get. But in the agonist, you can get all the cohort. And my experience.
There's a limit of days in antagonist like agonist. You said agonist more than 10 days. Antagonist
No.
minimum. No,
antagonist, you cannot intervene because if you wait, the cycle will be lost.
Yeah, just structures. Yeah. Thank you. Sharif, you have
Thank you, Professor Hassan. Yes, I have a question regarding the luteal support. In cases which is induced by either pills or combination of pills and gonadotrophins prepared for natural intercourse, timed intercourse, or prepared for or natural intercourse mainly. Do you give luteal support? Do you insist on this? And if you give luteal support, what's your luteal support regimen?
Yes, I do. Yes, I do. I do always give luteal support. I always believe that high progesterone is important for pregnancy in stimulated and ICSI cycle. This is my rationale. And I start this like ICSI. So I give the HCG and I wait for 4 days and then I start the progesterone. 4 or 5 days. Vaginally, 3 times daily. Yes, vaginally.
3 times daily. So almost a full dose.
Full dose.
Okay. Thank you.
I restart Q&A. The first question, if the patient in case 1 came to your clinic, what will you do? Case 1.
I don't remember case 1.
I think case 1 that got pregnant after expected management.
I will try. She was in my clinic. She was in my clinic.
Your practice. So this is your practice.
Yes, I'll get it. Like case 1.
You give her empirical medication.
She had spontaneous pregnancy 6 weeks later. This was my patient. This was my patient.
Dr. Ashraf Salima thanks Professor Dr. Hassan for your effort. According to NICE 2013, you advised to go for IVF or advised laparoscopy.
They eliminated IUI from the pathway. So NICE guidelines 20, but there is a lot of criticism even in England to NICE guidelines. But they eliminated IUI. I'm from a group of specialists that do not believe in the value of IUI. So I agree with the NICE guidelines. Not all people agree with this, of course.
What is the expectant management? Only timed intercourse?
Awareness of fertility physiology and timed intercourse.
Is laparoscopy essential for diagnosis of unexplained infertility, or hysterosalpingogram is enough?
Diagnosis of unexplained infertility is based on 3 investigations only: semen analysis, tubal patency, and progesterone. This is to put a patient on a track. You are not diagnosing the cause of infertility. Definitely, there is a cause of infertility, but you want to put a patient on a track. To put the patient on this track of expectant treatment, IUI, ICSI, you have to have 3 investigations. only.
So, how do you do the reduction in a case of more than 2 intrauterine sac?
Reduction.
Fetal reduction.
I don't do reduction for twins.
More than 2.
Yeah, I remove one.
May we consider a case of unexplained infertility despite early grades of endometriosis as laparoscopic intervention isn't necessary?
Muhammad, can you repeat the question because the voice was off?
May we consider a case of unexplained infertility despite early grades of endometriosis as laparoscopy intervention isn't necessary?
هو الصوت وحش تاني برضه.
He asked about unexplained infertility. Can we diagnose unexplained infertility despite the presence of minimal endometriosis or not?
To diagnose unexplained infertility, you do 3 investigations: semen analysis, histosalpingography, and progesterone. If you do laparoscopy, then you chose to do laparoscopy for this patient, and you got it out from the category of unexplained infertility. But you chose to do this. So it's very important in this presentation to state that there are 3 investigations only. And just to answer the question, no, of course, if you find endometriosis, she is not explained infertility.
What is your protocol to prevent bad endometrium?
The lesson to learn is that the duration of estrogen treatment could reach, as Professor Gaffer stated in one of our webinars, could reach as 20 days. So this is an important lesson, that you can wait for 20 days giving progesterone till you have the endometrium that you want. And then the incidence of thin endometrium will drop to minimum. This is one. Second thing is that some patients who don't respond to exogenous estrogen, they respond to endogenous estrogen. If you are using HRT, the dose is 8 milligram. My dose is 8 milligram per day from day one. From day one of the cycle. This is very important, from day one of the cycle, because it made a lot of difference when we give treatment from day one of the cycle. And I think that Sharif presented this data a couple of months ago, and he got those papers, right?
Yes, in the first webinar, in the first EFRE webinar,
I think yes, you did this.
Yes.
You presented this.
Starting at day one, starting with
treatment
8 milligrams.
Right?
Yes, starting at day one, 8 milligrams.
Day one, yes.
Yes, and according to the studies, you can wait up to 3 weeks of estrogen therapy before saying that this lady, you can't increase the endometrium anymore. So don't give up before 3 weeks.
This is the most important lesson. This is the most important lesson. Those day of start and duration. Right?
Yes.
Right.
Right, definitely. Right.
Last question. Do you trigger before IOI or not?
I don't do ovulation. I don't do IOI. But the data indicates that if you trigger before IOI, you can do IOI on the day of the trigger or after the day of the trigger, and the results with the day after the trigger are better than the day on the IOI on the day of the trigger. But I don't do IOI.
Yeah. Actually, this is the last question for Dr. Hassan. Thanks, dear professor, for nice presentation and fruitful discussion. Thank you, dear professor.